So what I want to present to you with the forces within is more like a concept of how to look at the data just in a different way than simply put some certain value into a normative range or something like that. So talking about the forces within, we would actually talk about force, of course. So we will talk about weights or maybe weight distributions, something like this. We can also talk about vectors. So which way does my force act towards? And we can talk about torques. So a torque is something that sounds highly complex, and if you're not deeply involved in biomechanics, that's really something that is already frightening and may give you a bit of an impairment in following along, understanding the concept. So this is what I want to try to break down a bit, make it easy, applicable also for clinicians like you, like me, that are not too much into that kind of physical laws and everything. So, as we're talking about force, of course, a bit of a definition must be, so we are not on the same page. So, force is expressed as mass per gravity, so that's basically it. And if you multiply that one with the other, you get the force which is expressed in Newton. And well, it's just simply a value of that expressing how much force I need to exert in order to move myself against gravity, which normally is also defined by the body weight that I'm acting against the gravity system of the Earth. If I talk about the vector, the actor is the orientation of the force. If I'm stepping down with the foot like this, my force vector probably goes up like that. If I'm landing like this, then my force will move more to the horizontal. So that is the vector, so the direction the force is traveling to. And then it's decisive which joint that vector is actually passing, and in which distance, at which orientation towards the joint. Is it posterior from it? Is it anterior from it? And this then will define the spatial distance between the vector tip and the center of mass, which is a lever arm. And that lever arm will create a torque. Well, in a simple example that I show you on the top image here. So we have our pelvis, just looked at it from above. So your center of mass will be somewhere centered on top of it. Now imagine this will be the greater trochanter on the hip joint, just pointing out like that. So your ground reaction force in a step will normally act up directly into the center of the hip joint. Then we have a distance between the center of mass and the ground reaction force. The muscle that is active to withstand that lever in the coronal plane will be glute medius. So we have another distance added to this. So the entire distance, the entire lever that we're talking about ranges from here to there. Now, if that lever arm is decisive for the force I need to exert in order to withstand gravity, then shortening that lever arm is a probably well-equipped compensation to give us that release. So therefore, you could simply rotate the hip inwards slightly and thereby reducing that part of the lever and therefore decreasing the force that needs to be exerted. Easy pattern and very common to observe on a regular patient. As for the torque, that will be the effect of the orientation of the joint force and its vector on a single joint. So is the vector running in front of the joint or posterior from it? I already said it. So maybe if we're talking about the coronal plane, is it running left or right from a joint? Also, this could be a question, so we'll see that in a live image later on. So that will be well, some kind of a sample. So what you see as the leg axis now from the lateral, this 3 times the very same leg axis. But we have a different ground reaction force vector which is pointing into different directions, thereby passing the joints in a different distance. So in the first hand, we can see we have the vector crossing the ankle and the hip joint, but moving posterior from the knee joint. This would act as a force that would fold tibia and femur together, therefore creating a flexion torque. In the second image, we can see that, well, the vector is directly crossing the knee, but is in front of the ankle and also of the hip joint, and therefore will be able to act as a dorsiflexion force in the ankle and to a flexion force in the hip or in the pelvis. So these are the torques that I'm talking about. So the gravity pulls me into hip flexion, so we have a flexion torque. And gravity also pulls me into an ankle dorsiflexion, so that's a dorsiflexion torque. So normally it's that simple. It's not too heavy to comprehend, but in that case, now we talk about an extension torque in the knee as that vector runs in a direction that it would pull the femur towards it, and therefore moving the knee into an extension. If I just give in to that force, it would move my knee into extension without any muscular activation. Now, to put this into maybe a mathematical model, which might be hard to follow along, but still is easy to understand. If you're lifting a box like that, we all know that this is not the way to lift a box, but hey ho, there are people I have heard that do that like this. So if we now estimate the mass of the box as 10 kilograms, that is the weight we need to lift. Now in this position we have other weights we need to lift because the head is weighing something and we need to elevate this against gravity as well. The trunk has a lot of mass, of course, and needs to be elevated against gravity as well. Where I'm standing, this is where my ground reaction force shoots up. And again, we are perfectly able to calculate a lever arm, so we'll come to that. Now that would be more the way we talk about when trying to make patients understand how to lift a box properly. Now, in this case, still we need to lift 10 kilos, don't we? So the mass doesn't change. But we have a mass of the head, which is still at 5 kilos, but just by the realignment of the trunk, which is sitting on top of the pelvis, so the pelvis takes over a very large amount of the weight of the trunk, the weight of the trunk is reduced to 5 kilos. Now, let's talk about the lever. So the lever arm is the distance between the ground reaction force and, well, where the force of the weight of what I need to lift is acting downwards. So therefore, if we have 70 centimeters on a weight that weighs 10 kilos, which represents 100 Newton, then we just multiply, 65 centimeters per 100 Newton, we end up at 63.8 Newton meters. This would represent the torque. So it's the Newton meter. And now you can sum up all of those values and you end up in the proper result of your total torque that you need to act against. Now, doing this on the right-hand side image, we already see torques are getting way lower just by the positioning of the body. Now, this was simply calculated. It's just so in studies I also had some biomechanics lessons and everything, so I was able to calculate this. Then my niece had her diploma done in biomechanics this year, so I was able to easily comprehend because I learned with her. So then it was all there, but of course this is not all there in clinical daily life, and this doesn't have to be because we don't need it to the decimal value. So we just need an impression on understanding on what a certain body position is exerting as force, not the plain value. That's not necessary. Now, again, looking at the full images. So in the left-hand side, we end up at a total torque of nearly 150 Newton meters, whereas we have only 25 Newton meters on the right-hand side. Now, if we take the right-hand side as a reference, we talk about lifting 10 kilos. On the left-hand side image, this would represent 59 kilos that you need to lift. This is, well, the 6-time higher load that acts on your bony and muscular system when you want to lift this. And of course, that's what you end up with, don't you? So that's basically what we see in daily life. So that was the technical instruction. Now I get to some, so normally when I do some presentations on the clinical part, I normally always go a bit off topic, try to make the principle understand first in, well, some, let's say, daily life sample before we start talking about spine measurements or leg axis gait analysis stuff and everything. So therefore, today I want to talk about Tiger Woods. So should be well known to everyone, even if we're not totally familiar with golf. Maybe we heard his name and we know that he has been a very successful golf professional. Tiger entered the Pro Tour in '96, had his first tournament not even a year after, and won a total of over 100 tournaments during his career. He was, many years he was world number one, and won a lot of prize money, of course. So even if I'm not including any advertising, marketing, or anything that he has earned with his association with several companies, but just as for prize money, he ends up at $120 million that he earned during his career. So this is the upside of the story, but we also need to talk about the downside of the story. So this is, well, on a professional athlete, you will always deal with injuries, and Tiger had a lot of them. And these were the most severe injuries that he suffered from during his career. And if we just look at the years, we can see that the vast majority of injuries occurred in the second part of his career. So we talk about, well, last tournament he played in 24, so we talk about a total of approximately 96 to 24, so 28 years of professional golfing. So I think after 24 he hasn't participated in any tournament anymore. So, but just having the early years and the late years, so then the vast majority of injuries happened in the late years as he got older, of course, and as he got exposed to more and more torques over his career duration. So what can we now transfer this into numbers? Tournament participation. Between 96 and 2009, so first half of his career, he participated in 240 golf tournaments. Between 2010 and 23, only 120, so decreased by 50%. And even worse, talking about the prize money. Up to 2009, it was $93 million. And from there on, 28 million. So going down by 70%. And one could argue if 28 million is a low number, but basically for him, it's a different story, and maybe injury prevented him from earning more and more and more money. I think with his association with Nike, he was able to generate way much more money, but basically in terms of sports performance, that's some kind of a number that reflects the outcome of well, the physical activity, the injuries that come together, and then they end up in maybe an injury that prevents from playing for an entire year, and then you cannot participate, and that's where you cannot earn money. Now let's start analyzing a bit. So this is a drive that he performs. just like this. So it's just played back and back and back and forth and forth and forth, but we can see this all in back repeat and can look at it as long as we wish. So that's the same principle that we have in the gait analysis. So we just let the video run until we understand. So, but sometimes it's just about also reducing the display speed a bit. So that's what we will do in a short time. So, but just talking about some physical data. When he swings the ball, so we hit the ball at a top speed of approximately 190 kilometers per hour. And we have a force that's acting to the ball, which is at 14,500 Newton during the collision of the club head to the ball. This all acts to a very, very small surface and therefore has a high pressure on that ball. This pressure needs to be built up somehow. So this is physical activation, isn't it? So if you look at the ball, how it's deforming once it's hit, and whoever has already just had a golf ball in hand knows how rigid this ball is actually, that it is actually able to deform like this. This is the force that is acting to the ball. And the force, again, has to be exerted from a certain source. Now, that's the deformation a bit larger. Now, again, going back to physics. When Tiger swings, he aims for a driving reach of 300 meters. So this is the distance the ball travels after he hits the ball. So what we can use for that is an impulse. We can transfer an impulse from our movement to the ball, and then the ball flies away. Therefore, we use, well, generally two sources, which is the mass. That could be the golf ball. So we need to transfer the impulse of 45 grams of a golf ball with a 200-gram club head. And we have the speed, which we know is at approximately 190 kilometers per hour. So this is costing energy. The energy, again, is defined by the mass that we're moving, the acceleration of some part of the mass that we're moving, so the driver needs to be moved, and the travel distance of the object that is hitting the ball. So we can alter the result, the outcome, the pressure that is acting onto the golf ball surface by the movement that we direct to it. So that means we can speed up our movement. That's acceleration, and that's again torque. So if I accelerate from this position like this or like this, that will be another torque value that we're talking about. And we can, of course, also modify the travel distance, means how far am I able to reach with the club with the driver and swing it down. So the more I go into that forward, in that counter movement, the more travel distance I have that I can use to accelerate the ball, the club head. Now, if we count everything together, we end up at an energy cost of approximately 78,000, well, Newton is the wrong expression, it's watt. So it's a lot, isn't it? So let's take a look a bit closer. Now we just look at the drive slightly slower. And now I used 10-time slow-mo now, which, from my understanding, must not necessarily be your understanding, but from my understanding, I can clearly see now how the impulse is redirected while the ball is hit from the foot of the front leg towards the thigh, towards the pelvis, the trunk, and the arms. So it's like a swing that moves through the body, counter movement, first swing hit, and there you go, and it all ends up at the shoulder region. So we have a lot going on there as maximum forces that are acting to different joints. This will be the simulation of, the movement between pelvis and spine, or trunk. There we go. So that's basically it. And every change of that movement will already create some torque between the pelvis and the trunk. There we go. Exactly. Exactly. So now this would be the ground reaction forces, how they act to, that athlete while he is swinging. So I chose, on purpose, I chose the coloring that we also have in the foot pressure measurement. So blue arrow will be on the right foot, red arrow on the left foot, and turquoise one is then the entire center of pressure, or then the center of the vector of the gravity. Now you can see that the arrows or the vectors are at different height, where there are some situations where that green arrow just points up really strongly. So that's really that moment where we have the highest energy and the highest forces acting. It's right there. So that's where we have a lot of going on here as maximum ground reaction force. That's where the arrow is shooting up the highest. This is where the driver speed is approximately in his fastest acceleration. Now if we just look at the alignment of the vectors, we can already see that our weight is already shifted towards the front foot, while the vector is passing medially to the knee joint. So we have a little gap between the center of the knee and the vector itself. This is creating a varus torque. So with every drive Tiger hits, he will always create a varus torque in his knee. So medial compression, and then if it's done on a repetitive way, this is of course at this level prone to be exhaustive for that very joint structure. So if I talk about, German athletes, you can see the same principle on Dirk Nowitzki. So that was our biggest star in basketball over many years, and he is at a body height of 2 meters and 14, and he had very specific training conditions. He had a personal trainer that was working really on an abstract level with him, but still now at the age of nearly 50, he's barely able to move anymore. So just taking one step in front of the other or after another is really something highly demanding for him. So that's what professional sport is actually providing you with if you're able, if you want to follow this along. So this is when I showed the American footballer yesterday. This is actually what I say what I mean if I say, the athletes are giving their body away, because this is actually what they do. So they're investing their body for sports performance, and then they need to deal with the residues of the forces they need to withstand in a repetitive way. Now looking at this from the side, you can also display those vectors from the side, and you can see that all of the vectors are passing the trunk in front of the pelvis. So that is creating a flexion torque. So it's nothing else. So you just need to see where that vector is going through, and it attaches here to the body, it attaches here to the foot, so then it will try to squeeze you together into flexion like this. This is what the force is doing, and your antagonistic muscles need to withstand. So with every drive that he hits, his lumbar extensors must work at their fullest. I'm sorry?
And the hip extensors.
The hip extensors as well, of course, yes, sure. Good point. So that makes already parts of his injury history quite explainable, doesn't it? So and this is where we see a good evolution of the swing behavior of Tiger Woods over the years. So if we compare just simply the reach of the driver between 94 and 2000, 6 years in between. You see that this is perfectly horizontal here, and it's pointing slightly up there. So that is the difference a golf player is talking about. Say they want to pay everything to get maybe 2 degrees more of a range of motion. That's the market, actually. Good market potential for any golf diagnostics manufacturer. And so this is the swing evolving. I don't want to go into detail. This is not a golf lecture here. But still, you can see that there are changes over time, adapting the motion pattern. Maybe we talk about some adaptations, modifications of the movement, because else that movement wouldn't be possible anymore due to pain or due to persisting injuries. So we need to work around that. So we talk about, well, continuously adapted movement patterns for more than 2 decades in order to avoid functional limitations and to optimize, well, the remaining function. And if we tell this for a professional athlete, then we can call this also for every patient, because this is what we normally see as compensation in daily life. So we adapt our movement patterns in order to remain the function. So the main function would be reflecting in a regular straight gait, that would be completing the tasks of daily life. But in some severe cases, it is decisive to see whether a patient is able to leave the house, going down the streets, maybe get something from the supermarket, walk back again, and then up the stairs again. So some patients will not be able to do that anymore, and that is a high impair for quality of life. Now, this was, well, the basic instruction, and now we just head to some samples where we want to try and apply this principle a bit. So now we have a sample here with a patient born in 1971, and we have some symptoms that the patient is bringing with him. So we have a low back pain, an instability, and well, a chronic pubical osteitis. So that's the inflammation that we have at the pubicles. So then that's what she's bringing with us. So maybe there has been some earlier diagnostics. She offers some complaints. All of this information is very, very helpful in order to get the sides, the look straight to what we want to see in the results. Now, let's look at that entire thing from the side. So we talk about the sagittal plane in the very first hand. Maybe add the foot pressure to it, but we can see there's a trunk inclination of 4 degrees to the posterior. Now, if you listened carefully yesterday, I talked about 3 degrees of an anterior tilt. That would be the norm value. So she's already 7 degrees away from that. So then she's leaning back like this. And if you now project the center of mass into the upper body, which is approximately somewhere here, and you can see the upper body is then positioned against this, then we can call this an extension torque, because the center of mass is passing the lumbar apex posterior from it. So then it wants to squeeze and fold together the upper parts of the lumbar curve. So that will be an extension torque. So the maximum mechanical load will be right at the apex of the lordotic curvature. Now, if we look at the abstract model, I did this in another sample yesterday, but that's basically how that measurement turned out when we just move away from the bony structure, but just go with the cubes. That's her curvature itself. So, and you can see there's one peak pointing out to the white in the lumbar spine, so a bit out of the gray. So that's basically this very segment. And you can see that there's a very sharp angle that is expanding between L2 and L3, and also a bit of a shift between L3 and L4. And now if you think about a vertebral disc, that could be right, constituted a bit like this. So then you have a very squeezed shape between L2 and L3, and then maybe already a bit of some pushed out segment part in between L3 and L4. So in order to withstand this extension torque, always think we need the antagonistic muscles or the antagonistic acting muscles to withstand and to counter work and counter orient. So therefore, in an extension torque, so if the gravity wants to pull me into extension, I need my trunk flexors to stabilize. It's always the same principle that we can apply there. Now, if we talk about the trunk flexors, then we can go for an origin or an insertion pain. So that if you always have that little tension on the trunk flexors, so either at the upper or the lower attachment point, then you have a bit of a strain that over time might also lead to some inflammation, and that could be something that can be perfectly going together with the inflammation at the pubical bone. Can tell you a different sample from myself. So when I started acting in an ascending chain with some sensomotoric insoles that were primarily chosen to activate my plantar flexor muscles, it was tibialis posterior was the target muscle. And once I inserted the insoles and started walking around them after a week, I started getting my pain at the costal margin instead. So that entire sagittal chain just activated, apparently, and at the weakest spot, it just came to life. And that's what I found as rather painful. I removed the insole for a short time period and started exercising on, well, an upright exercise therapy. So that was the time when we entered the market with the DIERS apps. So I had the kyphosis training done for 3 months, and after this, within the second month, I reintegrated the sensomotoric insole only for the exercises, not for daily life. And with this, I was able to implement the kinetics that would change by the insole over time, and that pain never came back. So it's just a bit of the weakest spot, the search for the weakest spot. This is where your complaints will start. Now, if we talk about muscle tension, we talk about maybe the chest muscles, because those will be also at a higher tension. At the muscular level, if we want to address it in detail, I'm not talking about, the trunk flexors or something like this. I want to go maybe for a specific muscle. Then we could address some critical muscles like the rectus abdominis, like the obliques, like also the major pectoralis muscles. So that those could be exactly those muscles that are key to realign. If we remove some tension here, maybe upright there, and maybe mobilize there, so then we would be able to modify. So just we need to find the correct switch. Let's go for another patient. So then we have a dynamic sample here. So that's her moving. This split is a bit different, so it's no synchronized information right now in this slide. But still, we can see a bit. So let's break it down. So we have a medical history. That's the symptom part. So the anamnesis. She is diagnosed with a hip arthritis, left more than on the right. And she has some kind of a band-like pain at the costal margin. So what's the indication for having a gait analysis done? Of course, in the first hand, it's the hip arthritis, but maybe in some principle like we are now working in, we are able to somehow correlate one with the other. So in a subjective way, if we don't go for kinematics or angles or whatever, we can subjectively see a Duchenne sign on the left. So whenever the left foot hits the ground, you can see that the trunk is bending towards that left supporting leg. There we go. And she goes for a bit of a Trendelenburg sign on the right, which is barely visible in this dynamic image, but if we now try to take a look at a fixed static image of that motion pattern, then we might be easier able to define the Trendelenburg, the Duchenne, or whatever we see. So that's basically what we went through yesterday. So just don't let always the video run, so that's the subjective part, but if you want to quantify, stop at a certain point of interest, and then we start working with what we see. Now, she contacts the ground with her foot, and somewhere at the center of the rear foot, as we see that the markers are standing quite upright, so that ground reaction force will just point up like that. Now we can see her center of mass being located somewhere up there, and that builds up a distance. And if we now see the trunk leaning to the left, this will highly reduce this kind of a distance. If I'm just taking her stance width and her width of the pelvis, I would expect to have a way larger distance, which in her case, due to that left lateral lean, she's able to minimize to really a minimum. So that is basically the Duchenne sign. So that is your coronal imbalance in the 4D motion actually. So you just need to find a certain point in time where this is actually working. So if you remember yesterday's clinical gait analysis part, you see that the right foot is close to leave the ground, so that's the end of the loading response on the left leg. So this is exactly where I would expect a Duchenne sign to happen. Now, looking at the loading response on the right-hand side, then we can already estimate a bit of a shift of the pelvis to the supporting leg again. So that is more like relation to the to the Trendelenburg. So again, we have a rather straight calcaneus, which then we have our ground reaction force acting upwards. We have our center of mass acting downwards. We have approximately the same distance as in the left image. But this time, oh, I'm sorry, that was too quick. We're moving this way, so we're shifting the pelvis outward, therefore moving that foot inward. You can see that only just from the width of the feet, the distance of the feet one to the other, that this one is wider and this one is way more closer. So what I do is I move my base of support medially and therefore approximating, well, the center of mass. So it's the same principle, just one time it's from top to bottom, one time it's from feet upwards. Right. So that's how we would clarify. So I would never clarify this directly from the video, but just from that static image. That makes it way easier. If you go to a static image, the video can still help you because then you can get a first impression of the repeatability of the pattern. So maybe that Trendelenburg only happened once because she got unstable and everything else is perfectly fine and she doesn't show any signs. Then I would never refer to that one static image. So but once I see this is happening all the time in 2, 3, maybe 4 gait cycles, that's perfectly usable. And then I would actually go to that very image where this deviation is shouting out the loudest, because this is actually where you can make it understand to the patient perfectly well. Now, the center of pressure displacement, that's what we see as a distance between the feet. So that's exactly what we have here. So 6 centimeters on the left loading response and only 4 centimeters on the right loading response. That's basically it. Now, Let's try to correlate. So we're still dealing with some symptoms, and this is something that we need to somehow deal with and somehow find a way through it. So the plumb line deviates 15 millimeters to the ipsilateral, coronal imbalance to the ipsilateral, so to the supporting leg, towards the supporting leg. Now, this is where my center of mass goes through, and if you just look at the spine, how it is acting or reflecting against that yellow arrow here, so you can see that there's a slight right bending there. That would be a torque into a lateral flexion, and that would be a lateral flexion to the left, because this is how the spine is now folded together. So the maximum mechanical load in that case would be, again, the maximum deviation. So you see that the distance at L4 is actually the largest, so that's where your maximum mechanical load is. And the muscular strain would be at the antagonistic part. So if it's pulling me to the left, then my lateral flexors on the right need to stabilize. So that could already be one point that we can integrate. Now let's talk about, well, hip arthritis, like say we have a Trendelenburg and a Duchenne sign that should show the function profile quite well. And talking about the band-like pain at the costal margin, that's where it gets interesting, because then we have our moving subject here, and we have some kind of a plausibility of the movement pattern, which always try to align the eyes towards horizontal level. So if I'm moving against this and my lateral flexors on the right need to withstand and to hold, at a certain point I need to upright myself. So that means I am in an elongation of my trunk flexors, still they need to hold, and still I need to somehow upright. So that is a very critical part for this lateral flexor region to get well stimulated at a level that is way too high, and therefore getting well some constraints in that side in addition. So then we have our level of the head, which we can estimate. So if we just look at the ears from the back of the patient, so we should estimate that the ears should be in line with the horizon. So that would reflect the eyes if we're not seeing them from back. Now we have our spinal alignment, and we have our pelvis alignment. The maximum deviation is at L4, and the realignment happens at T10. So this is where she moves herself more to a vertical level again. And that's exactly what we can see in the 4D motion, because this is her dynamic profile, that's how she's moving. And if you followed along yesterday, so that rotation that we can see here, starting from the pelvis and directing more and more to the asymmetry, we'll get a little peak here, and then realign and move back to the symmetrical. And at the level of C7, she's rotating perfectly symmetrical from one side to the other. So that's how my eyes can perfectly keep focused towards the horizon or to my travel goal. So if I see such a kind of a deviation, so that's basically always a sign of some block, some muscular deceleration or higher acceleration that we somehow need to consider when it comes to relating this to symptoms. And if we talk about a T10 level, then we are nearly there. So then again, we can talk about the dermatoma, and this is actually the model that I was referring to yesterday. So that will be that level of dermatoma where we are here at the T3, but now we are talking about the T10 level, which is the innervation of the obliques. That's the innervation level. So this is where my nerve roots just go to the periphery to innervate the oblique muscles. So therefore, we can talk about contracted, maybe weak obliques on the left side, because this is where I'm giving in and compressing. We have elongated and overloaded obliques on the right side. The glutes should be weak, otherwise a Trendelenburg or Duchenne would not be necessary. If we move this to the bone level, so we have a marked natural flexion of the caudal thoracic spine, and T10 acts as a pivot point there. And on the neural level, we can maybe think of a nerve root irritation at the level of T10. And that all goes quite well together with the symptoms that our patient has. So we have some starting point, not necessarily a decision point for therapy, because if we know about costal margin pain, we maybe know what to do as for therapy, but we have a starting point for documentation, maybe also as a starting point for a before and after, to make the patient understand. And maybe if we now correlate the Duchenne sign with the strain that we have here that is maybe causing the costal margin inflammation, that or irritation, that could be something that would enable us to make the patient understand that, look, of course you have your pain here, but the real problem is here. So we need to strengthen here in order to get you that one sorted. So the patient in the first hand, if I just tell him, will never understand. But if I can make him follow along the measurement results, I may be able to do so. Having a third patient, so with a medical history or an anamnesis of a visible hyperkyphosis, which is associated with low back pain, that is no surprising sign, I think. And we talk about a shoulder and neck pain symptoms that come along with it. Maybe that patient has his highest pain point at the shoulder and neck level, so that's why he visits the clinic, but then we can see his kyphosis. Maybe we can also talk a bit and then reveal also low back pain is persisting, but that would all add to how I look at the data, of course. Now, that's his measurement result, and let's turn him to the side. If we talk about visible hyperkyphosis, why not start with this? So, of course, a visible hyperkyphosis is something that we can see by the eye, so we don't need a measurement device for that, so we can... Where's it gone? Has it vanished? Okay, let's see. Where's it gone? Simply vanished from the slide, okay. No matter what, so we will deal with him at a later stage again. Where was I? No. Let's break down, so let's go for the postural parameters. So, a kyphosis angle of 85 degrees. There you see a lordosis angle of 39 degrees. And a trunk inclination of 11 degrees to the anterior. I think nothing more, does it? No, he stays. Well, okay. So those will be the parameters that we want to focus on, so not more in the first hand. This is how the force, the ground reaction force is acting upwards. This is where my center of mass is estimated to be. So in a kyphotic posture, that center of mass should normally be more forward bent. So that's what we can estimate here as well. Now, if you now imagine a head on top of this, then it's probably positioned somewhere here. And if I talk about 5 kilos of the head, then we can talk about this in the second stage. In the first hand, we just simply look at where our forces are, and we will see that our gravity vector will pull us into a flexion. So we have a thoracic flexion torque, and we also have a lumbar flexion torque. So both act into the flexion, thereby acting against the regular double S shape of the spine profile. Now adding the head to this, you see the blue arrows here, which are again building the lever distances. well, this is even way more bent forward, so that will be a cervical flexion torque as well. So the entire trunk tends into a flexion. So this is where my entire dorsal chain needs to activate to withstand and to pull against it. So that means we can talk about the cervical extensors. With the high tone in overloaded situation, we have the thoracic extensors, which let down tone because thoracic flexion is, well, what we normally would expect to be. It's just a bit higher in this case. So then the tone goes down and the flexors and the extensors are to be considered as weak. And we have the lumbar extensors, again, which are pulled into flexion, so the extensors need to increase the tone and therefore act as overloaded muscle group. Now, just go to the abstract model again, and then looking at well, the risk sheet for osteoporosis. That is part of an add-on that we can deliver with the phometric system. So that's part of a study that has been conducted in Hamburg at the university clinic, where they just compared kyphosis and lordosis constellations in individuals and calculated a risk level for osteoporosis and for vertebral fractures. So that means if I have a high degree of a kyphosis with a flat lordosis curve, then that ratio is way expanding towards the flexion of the thoracic spine. So then my black dot will just move towards the red, because then at certain levels my fracture risk will be increased. And in his case, in his constitution, we can see that in all of the segments of the spine we are already talking from an increased risk for fracture of a vertebral corp. Okay, now, just another one. I think there are not so many coming anymore, so we are nearly through, but a fourth one you need to give me. So we have, well, what we call a psoas contracture on both sides, also rather common, I think, especially in sedentary activities. We have a low back pain, which, well, fits quite well together, I think. Why does it? So let's see. That would be his lateral leg axis. And what we get as a subjective impression in the first hand, whenever he moves his left leg into an extension, that we see a slight posterior elevation of the pelvis a bit. So it's not only the pelvis rotation that would be regular, but also a bit of anterior tilt of the pelvis that's adding to it. Very, very subtle information from this image. Now, as for the hip extension, this is quite limited, and we can see this in a repetitive way over 4 gait cycles, and we always reach somewhat around 12 degrees, not that much more, should be 20, so we are already limited in the hip extension. So now we want to refer this to the symptoms. Let us see, how can we do this? Well, the psoas contracture, if my hip flex is hyperactive, so then it's logical, plausible that my hip is not moving into extension sufficiently. So then, well, the low hip extension value is perfectly able to be explained by the psoas contracture, I suppose. But what about low back pain? Now, let's see. This is a graph that I inserted manually. As we talked about the 4D motion yesterday, you saw that in the pelvic drop there was some wrong graph in my software, so this is what I introduced there by myself. So in the way like Alina showed before, so just setting the table and adding a parameter there to be displayed. This is where I used to insert the pelvic tilt, which is the inclination value of the pelvis during the walking pattern. And we can see that the pelvic tilt just in average, rushes up to 30 degrees, just in average. So we talk about the up and the down, and in the max we are even at a higher value, but on average we have 30 degrees of a pelvic inclination, an anterior tilt of the pelvis. And if we put this into a time frame related to the gait cycle, we will always end up at the terminal stance. So for a male patient at this level, we would expect to have a pelvic inclination of 18 degrees. So we're way higher than that, with 30 degrees. And that's what we can then also prove and add to what we already discussed in a subjective way, but only subtle. Now here we can see it just loud out shouting.
That analysis, you can see also that the tibiotarsical is not reaching the 0 degrees of the...
Which one?
The tibiotarsal joint.
Yes.
The ankle joint. It
Yes.
never reaches the 0 degrees, so even the initial contact is... Dissipation of forces can also contribute to that.
Right, exactly. So also the ankle, like you said, so I just repeat it loud to everyone, so you can also see that the ankle as well is not moving into a proper zero position, so we always have a bit of a tendency of a plantar flexion. Some of it may be related to maybe also some increased foot rotation, but still this is a vital sign of the entire motion pattern, perfectly observed. Now let's see, that's how he's walking, and if we just look at the blocks, and again, this is nearly the very same pattern as we saw in that female patient we had before. So look at L3, L4, and L2 and L3. So both areas look a bit difficult to understand. So whenever he moves into that increased pelvic inclination, so this is where those end plates will really squeeze together. And again, this is some question of how fast is my display speed. So I can in the software I can alter the speed. So if it's real time or if it's a bit slower or maybe even more slow. So now I want to actually bring two informations together. That would be one, when does my pelvis move into that tilt? And how is my spine acting against it? So I need a rather slow display to actually identify. So that's why this is really running slow. So then I can actually see when my pelvis is moving into the extension, into flexion. I'm sorry, and well, L2 and L3 get to that compression position. So roughly. Implemented the center of mass of the trunk, located in the trunk. And well, this is how he moves along with it. So, and what we can see is that whenever he moves into that pelvic inclination, his lordosis increases and moves anteriorly and passes the ground direction, the center of mass to the front. So that is creating an extension torque and wants to squeeze the lumbar spine into an increased extension. So that means we have an aggravating factor of a long kyphotic curve. So that's one thing. So you can see everything that expands from the lordosis apex is rather long distributed. We have an anterior pelvic tilt. And we have thus we have a lordosis angle of 46 degrees. So male patient, maybe 35 degrees is okay, maybe 30 would be better, but 46 definitely at the high end. Now, a stenosis. So I translated this with a translation of PowerPoint, so sometimes it just misses the spot a bit. What we can tell is actually, of course, morphological contact between the bones of L2 and L3. We would more talk about maybe a blocked situation, no matter whether this is, so we don't discuss about muscular-related blocks or a bony-related block. Of course, if we have bone masses pushing against each other, so we would talk from ossifications, and therefore maybe that stenosis is something that we could already tell as a diagnose, but in the first step I would just call it an approximation actually.
Kind of functional stenosis.
Right, exactly. So it's just a situative one. Exactly. So, there we go, that's the profile. Again, we can see that height loss and the compression between L2 and L3. Never mind the accuracy of morphologies. The morphology will always guide you wrong if you look at it into detail. But still, if you have an alignment of the lordotic curve like this, we can estimate that the bone will deform slightly. But in general, that shape and that constitution and the positioning of the bones should reflect the reality quite well. So, then we have a sagittal shift between L3 and L4, and again, so like we discussed yesterday, that is a larger step than the one that we saw yesterday, and every structure that runs posterior from the spine will need to move along that shift, will always need to take this step to the back in order to run down properly. So that is basically what we can see also again in the curvature. So here we go. That's exactly what shows us this shift of the segment quite well, also out of a static image. Now, that is absolutely explaining about low back pain in his case. That is not the general finding in all low back pain patients, of course. So that is a very blurry complaint, and low back pain has so many issues, but maybe the results of the measurements help us finding the individual reason for why the back is hurting. Now, we talk about the trunk flexors that are supposed to be overloaded and weak. We have trunk extensors that, on the contrary, are contracted but still are weak. And we have hip flexors that are contracted. So that's the psoas contractures, so we can take this one to one, and we have it. So what is the consequence? So the consequence, so the review to 25, so that was basically my presentation in the DIERS Academy last year. Where do we treat? So do we treat where it hurts? That is normally not promising for the long run, but we treat where we find some dysfunctions. So that's the outcome of the measurement. So then that could be a good approach for therapy success in the long run. Now, where we find the dysfunctions, there we go. We already defined the dysfunctions just out of the measurement. That's basically how we use the measurement data to refine and to get us an information about, in that case, the forces, the torques, and then the muscles that need to withstand. And a muscle that needs to withstand needs to contract more. The one that gets shortened, that will also reflect in the structures. And that's where we can start our treatment. And secondary, we can use all of those results and all of the findings. Well, we can use the findings and then the results, bring those together in order to make the patient know. And again, that simple example from yesterday, if I'm having shoulder pain as a patient, I expect to be treated at the shoulder, and nobody cares about the kyphotic spine. So making the patient understand, look, shoulder may be the one point that is hurting, but the spine is actually where we need to interfere. That's something where measurement results can actually help you in informing the patient and make him understand and building up compliance and trust. So now I think it's the last sample. So where are we in? No, I think it is. So this must be the last one. So we have a knee arthritis on the left. Why on earth should we perform a spine measurement here? So it's a knee arthritis, and normally knee arthritis is already known by some X-ray that has been done, and we can see the bone, and arthritis is there. There you go. So, but we talk about function, don't we? So that's what we're up to. So it's not about, okay, the bone is like this, so one patient is able to compensate more on it, over it, and some patients are not. And so this is what we are dealing with when the patient enters the clinic. Now, we can see in the first hand that there's something going on in the thoracic spine. So we have a local deviation, so that's the yellow line here, which really points out locally to the right. And this is also reflecting then the rotation locally, so that always is a counterplay. And we have the center of mass pointing down like this. It's not necessarily acting from C7, but in that case it's just reflecting the plumb line. Now, the torque in that relation would perfectly be assigned to a lateral flexion to the left. So this is already indicated by the yellow shape. So that could be an overload of your scapular fixators at this level. So we talk about the level. Where is that torque acting to? So is it just somewhere in the lumbar spine? Is it somewhere in the thoracic spine? And this is the muscular level that we want to talk about. So in that case, maybe scapular fixators are some critical point that we might consider. So what? Where do we see the indication for gait analysis if we have that kind of a diagnosis and that kind of a finding in a static image? So it's not about diagnosis. The diagnosis is already there, but the functional status, that's what we want to consider. Building understanding, compliance, and acting as a cornerstone for therapy. Now, let's sum up a bit, and then we move on. The ground direction forces and torques, and how they affect gait analysis. So we know that the ground direction force is the force that the ground exerts towards us, which is standing in a good relation to our body weight, and the acceleration that I let my body weight rush down to the floor, of course. And we can express this as a vector. So the force runs in front of the joint axis. We have an anterior movement of the proximal segment, and if it runs behind of the joint axis, it's a posterior movement of the proximal segment. Now we have our walking pattern here. So this is the entire stance phase. No, is it? So it is the entire stance phase. And, oh, sorry, that was too quick. So this is the ground direction force, how it is estimatable to be located towards the body and the joints. Now we have several torques in there, so I don't want to go through those over the entire sequence, but maybe speaking from one, so that again is the load response. So we have our force vector pulled towards the center of mass here, so that's the moment where this has already happened. And we can talk about a movement direction of the hip, which is moving into flexion. We measure a knee in flexion, and we measure an ankle in movement direction to dorsiflexion. So the plantar flexion that we see initially should get less during that phase. So that's what we see also in the lateral leg axis. Now as for the torque, that's what the torque is acting just by the vector and how it's passing the joints. So it will try to move your hip into flexion. It will try to move your knee into flexion, and it wants to move your ankle into a plantar flexion. So that's basically what the position of the vector moves those joints to. So now putting this aside, What do we need when the hip is moving to flexion and the torque is also moving to flexion? We need eccentric contraction of the hip extensors. We will need an eccentric contraction of the knee extensors for the knee flexion torque. And we will need a concentric dorsiflexor activity in order to pull the tibia forward. And well, that's everything that is happening there. And if you're just looking at the sagittal plane in gait analysis, nearly every gait deviation refers to a weakening of one of those supposed to be active muscle structures. Now back to our knee arthritis patient. That's how she's walking. Talking about a knee arthritis, she was born in 53, so we're talking about 70 years of age. So that's just a different story than we had yesterday in the hip arthritis with 46 years of age. Now, that's the Trendelenburg. Left side walking, and then the stance image. So that's end of the loading response on the left side. So that's pelvis shifting to that side, so you can really see how this is really pointing to the left. That's a weakness in the glute med. There we go. That's the representation. And if you look at the leg axis, just in relation to the yellow arrow, that is a valgus torque, which gets initiated by the femur, because the tibia is running perfectly along the yellow line, but then it turns out, so that is the valgus torque, and moves the leg into that lateral compression. The valgus angle here, you can see it 167, so that is 13 degrees of a valgus, so clear valgus deformity on the leg during the stance, so that's where she normally bears her weight. And we have a compression of the lateral compartment of the knee. Now her pelvis rotation ranges from 9 to 5. That sounds like my job in week times. So that is an excessive pelvic rotation to the left. So because it's supposed to be 5, but it's already achieving 9 degrees. So that could be a sign for weakness in the gluteus maximus muscle on that side. So now let's get back to the static image. So how can we connect the scapular fixators to that? This is how she's standing. Weakness in the glutes. We have a lateral flexion torque. And this is the force how it's acting up in a muscular way. So that is perfectly aligned with the muscle fibers. So if this is my weak structure, the weakness gets transferred in fiber direction to the lumbar fascia and then arriving in the latissimus muscle, just caudally from the scapula. So is there something else? I'm not sure. So there we go. No? Oh, sorry. No, that's okay. And so we have this force chain on the left side image, so which comes to a point at the hip, and if we now use that force that's acting upwards, so weak, then your scapula needs to fixate it, so your cranial structures need to hold more in order to prevent your upper body from falling down and to move into a shoulder tilt. So the functional outcome. Just if you look at, when you look at the foot pressure, you see that the foot is always contacting the ground at his full base of support. So there's no lowering of the forefoot while the heel is touching the ground first. It's just a flat foot on both sides and an insufficient step length overall. So you can see that the feet are really touching the ground at a short distance. now. Oh, this hasn't been translated, so that's the step length on the left and the right. So it's only 40 centimeters on both sides, so it should be somewhere around about 50, maybe 55 centimeters. That would be sufficient step length. Then we have a cadence, which is at 131 steps. That's a bit much, so we want to have 110, maybe 115, that's okay. So that tells us about the step frequency that is a bit higher. And we can see the ground reaction force, and we can see that there's always one peak a bit higher and the other a bit lower, while they are supposed to be at equal height. And that altogether would build up a consequence, which could be the training of the dorsal diagonal sling. But we need to consider the age and the functional status. That's what we did the measurement for. So the follow-up assessment might focus on the lateral deviation, on gait parameters like step length, like cadences, and the knee axis. Now, we need to consider, that is again our expertise, whether these kind of exercises are adequate for a 70-year-old patient. So that's basically just a sample, but I'm not sure whether this is actually achievable.
I think that there's something here that should be taken into account because...
Right. So that's basically exactly, so I will just repeat loud in short term. So if we see her walking and see how she's acting in her left leg axis, this is always tending into some internal rotation, and this is surely not only a problem that's related to the knee, but for sure also to the hip. And well, then symptoms appear at the weakest spots. So in her case might be the knee, but still the hip is something we need to address. And if we talk about gluteal weakness on medial and maximum sides, so then that's definitely something we need to consider also in therapy. So that's really vital, I think, for her to also get hand on the knee pain. Absolutely, absolutely. So in the end, all this force, vectors and torques, we don't want to have this calculated just to a decimal level, not even into a really fixed value. We want to use it as an impression. So just think of a force, how it's acting, how the force vectors could be interacting, and what torques result out of this. So that is basically what I want to show you with these samples that I showed you. So all of this should be less complicated than you find it in any biomechanics book. So they can give you a good idea on an additional informative field in diagnosing and assessing well, the status of a muscle chain, of a functional status, and therefore may be able to just add some kind of another dimension to what you already do with the system and how you use the system. So if you come back next year, I will for sure use my presentation I did last year in the German Academy. So that's the sagittal balance. That would be just another point of view on the functional status of a patient, on interpreting result parameters. So it's just about take the best out of this, what I presented. It's not always needful to have everything implemented to one own concept, but if there are some ideas that you can convert to your own daily life, so then I'd be happy. So thank you so much.